on top there, just below Zoom meeting, there's a green thing. Then if you come across, you'll find speakers view. And then there's a big thing, full screen.
Yeah, the share screen. It's the share screen.
Yeah, it's easier for somebody to see if he goes on a full screen. But if he goes on a small one, you have to tap these dots here down.
Okay, so I go to.
When you go, if you put full screen, you just go there down, you'll find share screen, the green thing.
Yeah, I have seen it.
You found it?
Yeah.
You found share screen?
Yes, at the bottom.
Click on it. Yes, at the bottom.
Okay.
Click.
Yes. Then I can see this one. Okay.
Yeah, now you have to choose which one is on your. Yes, you're now sharing. Exactly.
Yes. Okay.
And then after that, yeah, you click on PowerPoint. Yeah, very good. Excellent.
All right. I think we are good now.
Okay. Anything? Hey, hello, Sanali.
Hi, Nyale.
Fine, you are looking very macho. With a banana and
this is the advantage of being in the Zoom meeting. You know, you can enjoy yourself from the comforts of your home. You know.
I like your Zoom attire.
The
banana makes you look very unique. Even me, I think I should.
The top may be okay, but the bottom, you don't know what someone is wearing at the bottom. You see.
If at all they are wearing anything.
No, I think everyone here is saying they are good guys.
Don't be too sure.
Good to see you, Hassan Ali.
Don't be too sure.
Good to see you, Hassan Ali.
Likewise, Nyale.
Yeah. Okay, yes, somebody wanted to give us a briefing of how we are going to go.
Hi, everyone.
Hi, hello.
My name is David Lechuta from DAFRA.
Yes, David.
Yes. So, Dr. Nyale.
Somebody who is in our school. I can hear a lot of children.
Actually, I should be the one. There are kids playing outside. Let me send somebody to make them keep quiet.
Okay, fine.
Yeah. So now.
Yes.
Doctor. So you'll moderate. So what we just wanted to discuss is how the meeting will progress from here.
Okay.
Yes. Now, and Dr. Diana Marangu has about 2 to 3 slides on what to expect on sepsis in pediatrics. So I think after Dr. Oweru, then probably you can just do the 2 to 3 slides so that at least when the question and answers come in, then we will all be on the same platform.
Okay. So what I thought, Lechuta, what I thought we can do is that to introduce me, I'll introduce all of them.
Yes.
Waweru Munyu, Diana Marangu.
Yes.
That I'll give the floor to Waweru Munyu to do the presentation.
Yes.
After Waweru Munyu has finished the presentation, I'll give Diana Marangu 5 minutes just to
sign in because
pediatrics.
Just wait.
Yes.
And then after that, I'll give Hassan Ali 3 minutes to comment. Then we can. Are you having a presentation first, or do we take a Q&A?
Actually, we have a presentation, and our presenter will be Mr. Bruno Dipao.
Oh, okay. Bruno, how are you?
I'm fine, thanks.
Yes.
How long is
I'm a bit far away, 6,600 kilometers, but...
okay.
Yeah.
How long is your presentation so that we can be able to manage time?
It is about 5 or 10 minutes. I can do it in 5 if you would like.
Okay, 5 would be good for us, so that after that we can take all the questions together, as opposed to first having the sepsis presentation, taking questions, then your presentation. Or do you prefer it that we do our presentation, finish, have a question and answer session, then hand it over to you to do your presentation?
Yeah, the point is I'm from DAFRA, So
Yes.
what I would like to present is our Meronia in some
Okay.
brief minutes. It isn't really related to the sepsis, although the drug itself can be used.
Wait, they've
Sepsis.
not added you yet.
Hassanal, you can
It's
mute
up
your
to
mic.
you to decide.
Okay, fine. Waweru, what do you think? Should we maybe first present, have the Q&A, then give Bruno Di Paolo the floor for him to do a presentation?
The only problem sometimes is that questions go on and on, but if such that the company doesn't have much time and people start falling off. So if their presentations are short, they can, mine are only 35 slides, so that should take about 40 minutes.
Okay, fine.
Or even less.
So I think the best format is that we go through a presentation, Diana Marangu's 5 minutes, and then Hassanali comments for 3. Then we give Bruno Di Paolo his 5 minutes, and then we go to a question and answer session.
Okay.
I agree.
We're good to go. Okay, so I don't know who will introduce Bruno.
He can introduce himself, then
I'll
we'll talk 2 or
introduce
3
myself.
sentences.
Okay,
All right,
fine.
Okay, Dr. Nyali, you'll just welcome him and then maybe he can just introduce himself.
Welcome him, then he can introduce himself. That's okay.
Yes, yes.
Okay, I think we've got a plan. The only person I can't see is Diana Marangu.
She was in.
Diana.
I'm in, Dr. Nyale. Sorry, I'm just not to do video right now because I'm very, I was going to sign in with my profile picture. I'm sorry, but I'm here.
You don't want us to see you. It's okay.
Just came from the hairdresser.
Okay, fine.
Don't mind for now.
So you've had the flow of things, eh? I think you're okay.
I was here throughout, Dr. Nyale.
Okay. So opening of the meeting, that's Lechuta's task, eh? I think so.
Okay, fine.
Calling the meeting to order. You want me to call it to order?
Maybe you can call to order, maybe because we also have a country manager. He's called Mr. John Dungu.
Oh, he's logged in. Maybe
he's logged in. Yes, he's in. So maybe I can give him.
Yes, Dr. Nyale, I'm here.
Oh, fine. Oh, okay. Yes, I can see you now.
Yes.
Okay.
Starts, yeah? Then we can proceed.
Yeah, I think then Lechuta, you open the meeting when the guys are there. You welcome them to the talk. Then give John Ndungu maybe a minute or 2 to say something.
Yes.
Then that you can invite me. Then we take it on from there.
Okay.
All right.
Okay,
That's right.
Okay, that's done. Unless somebody has anything else, A or B.
Maybe for the questions, maybe just to confirm, you'll ask people to write them or they'll just ask them verbally?
I think there's not a question and answer, a Q&A tab.
And maybe it's important when you're introducing, you tell the people to maybe write them or just...
So they'll write them in the chat because I can't see a Q&A tab on mine.
There's a chat there. I think they can use that one.
Because what we are using is the platform it's not webinar, it's a large meeting. So it doesn't have a Q&A session.
Oops, okay.
Although it is possible to write the questions down in the chat.
Yeah, sure.
So, and the chat can be private, but the chat can also be public to everyone.
Okay.
Yeah, that's possible.
Okay, so
it's usually easier if people write, because some people will ask the same question in different ways. Then the moderator can select those questions and select one of the speakers to answer.
Yes, that's okay.
Okay. Okay, so that means I have to be going through the chat and noting down the questions.
Yes,
so,
right.
Irene.
Yes.
You'll also be noting the questions.
Okay.
Then you can send to me so that I can see them. Okay, or you can WhatsApp, whichever works for you.
Okay.
Fine. I thought we were starting at 7. Oh, it's 7:30.
At 7.
We are
So
late.
it's time then.
We are late.
Yeah, we should start then. Okay, that's good. Me, I'm ready. So I think you can let guys in, whoever is responsible, so we can mute our microphones. Asanali, remember to mute yours.
Maybe just a few minutes, just we let in guys in.
At the moment, there are only 12 participants, so.
Okay. So I think we'll put both our videos and our mics off, yeah?
Sasa.
Breastfeeding and have symptoms or are confirmed COVID-19 case.
Okay. Hi everyone. Let's give then Amarango 2 minutes to log in. Are you able to join?
Who?
Hello, hi everyone. My name is David Lechuta. I'm a medical representative from DAFRA Pharma. And I'm glad that we have this meeting today on the updates in management of sepsis in collaboration with the Respiratory Society of Kenya. And I'm here to welcome everybody to the platform and to the meeting so that at least we can hear from our speakers and our panelists on how the management of sepsis has been evolving over time. Our moderator will be Dr. George Nyale. He is a consultant physician and pulmonologist at Kenyatta National Hospital, and also a chair of the Respiratory Society of Kenya. And he also practices at Karen Hospital. So allow me to take this opportunity to welcome our country manager, that is John Ndungu, just to say a word so that thereafter I can give the platform to Dr. Nyale so that he can introduce the panelist, the speaker and the other panelist, so that and then we proceed from there. So John Ndungu, maybe you can just say a word.
Okay, good afternoon, good evening everyone, and thank you all for joining us on this platform. Mine is brief, just welcome you again, and also welcome on behalf of DAFRA Pharma, Mr. Bruno DePaul, who will be handling DAFRA presentation for this evening. So for now, I'll take it over to Dr. Nyale to proceed with the moderation.
Thank you.
Okay. Thank you very much, ladies and gentlemen. I'm seeing we're already up to 68 guys. So usually RESOC, we are not so many, so we had opted to use a large meeting where we could all talk. But I'm obviously seeing in future, probably we need the standard Zoom meeting where other people are mute so that we have a lot of peace and cohesion in the meeting. So today evening, we'll be asking everybody who is not speaking to please mute their mic, yeah? Because if your mic is on, then it disturbs the voice of the presenter. So if you're not speaking, please mute your mic. If not, then we'll ask the host to mute you. And also you might not need your video picture unless you're going to be speaking. So we'll have, we'll be urging most of the people to write the Q&As on, the questions on your chat, and then we'll look for them. But we'll also give an opportunity for people to ask questions. That's why we chose the big meeting kind of format. So without further ado, I want to welcome you to this CME by RESOC. It's an update of sepsis. I hope all of you joining us are members of RESOC. RESOC stands for Respiratory Society of Kenya. And for correction, David, I'm not chair, I'm the president. In RESOC, we have presidents, so so it's a very big post. So
thank you, Dr. for that correction. Sorry for that.
So today we are going to have the main speaker, who is Dr. Waweru Monyo, who is a consultant physician and a specialist pulmonologist and critical care practitioner in the private sector. He actually transverses most of the hospitals in Nairobi. He's going to be our main speaker. Then we are going to have two panelists, a pediatrician, Dr. Diana Marango, pediatric pulmonologist, board certified South Africa, and the only PhD pediatric pulmonologist I know. So she's going to tell us about how sepsis looks like in children so that we can have the complete picture. And just to be fair to the men, I added another panelist, Dr. Hassan Ali, who is also a consultant physician, specialist pulmonologist, and critical care practitioner at the Aga Khan Hospital. So those are going to be our two panelists and the main speaker. So I'd want to invite Dr. Waweru Munyo to give us his talk for this evening, which is really the update of sepsis. Welcome, Dr. Waweru Munyo. Waweru, we don't have your audio.
Hello.
Yes, now we can hear you.
Now you can hear me. So thank you very much, Dr. Nyale, and the team for inviting me to talk about sepsis. Am I clear, Nyale?
You're very clear now. We can
as
hear
we
you.
all know, okay, thank you very much. As we all know, sepsis is one of the biggest killers of our time. Forget COVID. COVID is moving very fast, but sepsis has been with us for very many years. Indeed, in 1991 is when a committee was formed to try and rationalize as well as standardize the care of sepsis after it was found that sepsis really was taking a toll on many people. And at that time, the problem was that different people were managing sepsis in a different way. And therefore, there needed to be a way which was evidence-based to help improve the outcome in all those patients who develop sepsis. As you can see, sepsis is a huge killer, and the estimate as of 2019 was that 19.4 million people got sepsis last year, and as many as 5.3 million people died. So this is huge. And what we have found is that in the high income settings, outcomes are much better than in our settings in the sub-Saharan Africa and other developing nations. The reason why this has improved is that in the developed world, there is a lot of evidence-based practice, and people are doing things the way they should do them, including things like early aggressive fluid resuscitation, early antibiotics, early proper physiologic monitoring, interventions in different ways. And these interventions include intensive care, provision of vasopressors and inotropes as needed. And indeed, because there has been a lot of research, more and more evidence is becoming available as to what we should do to help these people who have got sepsis. Unfortunately, in our circumstances, sorry. My screening is hanging, sorry. Lechita, are you able to show the other one? My screen has hung. Sorry about that, people. Let me see if this works better. Yeah, now it's moving. Sorry about that. So in our circumstances, we have always said that we do not have data to inform different decisions that we make. But I came across this very interesting article by Lewis, and it tries to collate all the data available as of last year to decide to help us know what information do we have and what are the challenges that we have as sub-Saharan Africa to help us start working towards getting solution. And in summary, what this article showed is that really there is lack of data even now regarding specific aspects of sepsis management. And the reason for this is because our environment is different from what is happening in the West. For example, we do not have good ways of getting people to come to hospital early, either because they have no money or anything like that. So they come to the hospital quite late, and therefore we may not be able to assist them as well as they would have been assisted elsewhere. Secondly, we have a unique kind of etiology for the sepsis, because unlike in the West where most of sepsis is bacteria, nowadays viruses, and fungal infections, in our circumstances, we have to contend with infections with parasites such as malaria, infections which have by and large been eliminated in the West, like tuberculosis. And you'll know that HIV in all its manifestations leads to many different types of opportunistic infections. And indeed, if one does not have a high index of suspicion, one can easily miss some of these infections. Remember things like pneumocystis carinii, fungal infections like Cryptococcus, which occurs in HIV, and this can cause severe sepsis, and people are dying of this. We also know about things like Ebola, which in the West is almost non-existent. So all these things really demand that as Africans and in this sub-Saharan region, we need to come up with our own data to be able to say, okay, I have this gentleman who has come with what appears like sepsis. How should I go about it? I have this child who has come in with what appears like sepsis. What are the key things that I should do for this child? And I'm sure Dr. Marangu will talk a little bit about the children. The other thing that we find being a challenge in sub-Saharan Africa is even when we have finally made a diagnosis, our mortalities are still very high. As you can see, patients who had sepsis, 19% of them died, meaning if you come to hospital with just sepsis, 1 in 5 people will die. If, however, you come with severe sepsis, then you'll find that up to 40%, every 2 out of 5 of those people will die. And indeed, the 28 to 30-day mortality is more than half. So these are really quite serious problems that we have to contend with. And we need, as clinicians, to really work hard and know how do we help these patients. And why are we doing poorly as sub-Saharan Africa? Several factors come into play, one of which is lack of resources. And these resources are not just within the hospital setup. Remember, for a patient to be assisted, they have to come from their home. And we know that our societies are quite poor people. Therefore, in fact, there was a study which was done in Uganda where they found that people would show up in hospital unable to walk. Some of them would have symptoms which last about 14 or even 21 days. So this is mainly driven by the fact that this patient could not come from their home to the hospital. And sometimes they try other things. They try herbal therapies, they try magic, and many other things to try and resolve this infection. By the time they come, they are in trouble. The other resources that we have to contend about are those resources which are necessary in the hospital, starting from small things like syringes, needles, a working laboratory, availability of healthcare practitioners, that is nurses, doctors, availability of proper skills. For example, now we know that most counties have intensive care units, but do we have enough people to run those intensive care units? And I think it is important for us to come up with creative ideas. Telemedicine is one of those ideas which can really help. Many of us, I know, are practicing this. You get a call from a colleague in a far-flung place, and you discuss a patient's case. And that may help improve the outcome of that patient. HIV also causes problems, and this is because at the individual level, it reduces immunity, opening the doors for one to get infected by many opportunistic infections. It also creates situations where people develop malignancies, lowering their immunity further. Remember, HIV also has an impact on the socioeconomic capacity of communities and individuals. So HIV has really wreaked havoc on Africa, And we are happy now that things are getting better with more people getting on the antiretroviral therapy. As I had mentioned earlier, we know that many people present late in hospital, and therefore our interventions are delayed. However, there are even delays within the hospital where maybe a patient comes in, is recognized to have an infection. Unfortunately, they have to queue at the pharmacy, they have to queue at the cashier, they have to queue at the radiology section. And unlike in other situations, for example, cardiovascular care, where you come with a stroke and it's expedited, many people do not recognize sepsis as a bad killer as they recognize cardiac arrest, myocardial infarction and so on. But studies have shown that with every hour that one delays in terms of giving a good antibiotic, we have a 7% mortality. So if you delay this patient for about 4 hours, 5 hours, that patient's mortality has really gone up. Then there is lack of critical care services. This is not just the presence of ventilators and presence of intensive care units. We need people who are well trained to go through with the patient, right from admission, triage, and then expediting their getting into the critical care areas. And as I mentioned, telemedicine is something that is likely to help us in this way, so that even if we have few clinicians who have critical care know-how, they can assist many other people out there. Now, what is sepsis? Sepsis has the definition has evolved over time, and the latest we are dealing with is sepsis 3. This was defined in 2016, where sepsis was defined as a life-threatening condition caused by a dysregulated host response to infection, and this resulting in organ dysfunction. Previously, we had talked about sepsis being divided into many other aspects, and we will discuss them as we go along. Those have been found to be useful, but maybe not as well as what they have decided in 2016. And septic shock, this is circulatory, cellular, and metabolic abnormalities in patients, and this is defined as fluid refractory hypotension. And this, therefore, we require this patient to get vasopressors so that at least we can improve their blood pressure. And how do we identify those patients at high risk? And there's the SOFA or sequential organ failure assessment. I find this very important because it helps a clinician stratify a patient's risk of mortality. And what this looks at is, one, their oxygen level. And here we are looking mainly at the partial pressure over a fraction of inspired oxygen ratio. That helps us know how well is this patient ventilating. We also have a platelet count, which you inform us about hematologic system, Glasgow Coma Scale, which you tell us about neurology, bilirubin, you tell us about the liver, creatinine level will usually tell us about renal, and the mean arterial pressure will inform us about shock and the need for vasoactive agents. Now, going into greater details, this is how the SOFA score is done. What comes out clearly is that it's a cumbersome kind of thing, because you'll need to have some information which you may not have right at the point you are admitting this patient. For example, you may not have a gas in some hospitals, a blood gas that is. You will easily have a blood pressure measurement in most hospitals, but bilirubin may take some time to come back, creatinine may take some time to come back, platelet count may take time to come back, but a Glasgow Coma Scale will be available to you quite early. Now, having said that, in those areas where we are able to do this, it is an important thing to do because it helps you stratify your patient as well as prognosticate the likely outcome of that patient. Why this is important is because it helps one, even when you are talking to the relatives right at the point of admission, when you have all this data, you can prepare them for whatever is likely to occur. Now, to make it easy for the clinician on the bedside, there was the development of the QSOFA criteria. And the QSOFA criteria just takes things which are available for you. And you ask yourself, is this patient's respiratory rate more than 22? is this patient having any change in mental status? And is their systolic blood pressure less or equal to 100? And if they meet any of these criteria, that gives them a score of 1. If a patient has a score more than 2, that is 2 or 3, that patient requires to be quickly triaged and taken into a critical care area for rapid intervention. Indeed, your rapid intervention should start right at the point you see the patient in the accident and emergency or outpatient department. Now, when we compare these two, as I mentioned, and some of the information may not be available either in the accident and emergency or at the bedside, but it is a good criteria when you are trying to follow up your patient during their in-hospital stay. Indeed, what has been said about the SOFA score is that it helps you prognosticate a patient based on their parameters on that day. However, it does not tell you how that patient's outcome will come if you do the proper interventions. So even if a patient has a very poor SOFA score with a likely bad outcome, if you do the right things, you'll notice that the SOFA score will improve over time. On the other hand, if for instance, you may find a patient who is confused in casualty. Already that gives you a score of 1. And they have maybe a low blood pressure for whatever reason. If this patient's confusion is because he took alcohol, for instance, that may tilt your Q-SOFA score. And indeed, this patient is not dying because of sepsis. So it is important for the clinician to identify what is the main thing that is driving this patient's symptom. As I have mentioned, pre-existing chronic diseases may also affect the accuracy of Q-SOFA and SOFA measurements. Now, as I had mentioned earlier, we had this kind of classification before, where we have syndrome of inappropriate respiratory, SIRS, where we were looking at, is the patient having a temperature over 38 or less than 35? Is the heart rate more than 90 per minute? Is the respiratory rate more than 20, or do they have a PaCO2 of less than 32 and therefore means that they are breathing fast? And is their white cell count above 12? This patient would be defined as SIRS. Now, SIRS can result from many things, including burns, pancreatitis, and so on. So what now has been found is that this SIRS is an important one for picking patients who are at high risk of sepsis. So what we are doing now is to be able to get a patient early without too much waiting for the laboratory so that you can do a SOFA score. Triage your patient using the SIRS. And once you have triaged them, the next question is, does this patient have an infection or not? If they do have an infection, that patient is now in the sepsis group. But if they don't have an infection and their SIRS criteria is met due to other things, then you have to manage them as such. Indeed, there are some studies which have suggested that SIRS criteria is quite sensitive in detecting sepsis, but the Q-SOFA should only be used as a triaging tool to decide where do I manage this patient. Now, changing gears and looking at the pathophysiology of sepsis. Simply put, we have an infection which leads to inflammation. And this inflammation can take two pathways. One, it can be successfully contained, in which case the patient recovers, or it can progress and lead to a progressive inflammatory response, or it becomes uncontained and it spreads elsewhere. And this can be as a result of immunosuppression from various reasons. Now, when the inflammatory response has continued, you end up with endothelial damage, as well as, and that means that there is barrier dysfunction, as well as epithelial dysfunction, as can happen in the intestinal system. When there's epithelial dysfunction in the intestinal system, you have more bacteria translocating, and that now ends up causing worse. It becomes a cycle where you have multiple organ failure, hypoxia, apoptosis, and this can eventually lead to irreversible changes and host death. Now, going into greater details, we have pro-inflammatory responses after an infection, and we also have anti-inflammatory responses during infection. If one has an excess pro-inflammatory response, that is what will lead to leukocyte activation, and this is usually activated by things like pathogen-associated damaged proteins, and eventually you have complement activation, and you may have coagulation cascade activation. And all these things cause trouble. For example, if you have excessive cytokine release, you have damage to different tissues. If you have consumption of coagulation products, coagulation factors, you may end up with disseminated intravascular coagulopathy. So for one to survive this kind of thing, your body needs to have a balance between the pro-inflammatory and the anti-inflammatory response. Looking at it in even greater details, and we start on the left upper corner, you have a pathogen getting into the body. And what you need to stratify this pathogen so that you can make appropriate decisions is whether this is a community-acquired or a hospital-acquired pathogen. If you are dealing with a hospital-acquired bug, please expect that you are likely dealing with a resistant germ. And therefore, even when you are selecting your antibiotic or antimicrobial, you need to put that in mind so that you select one which will be effective in getting rid of that pathogen. Now, once the pathogen has entered into the host, that causes infection, and there are two types of responses. The first response is where we have the innate immune response, and this usually manifests as fever. You have a leukocytosis. Sometimes you may have a leukopenia, and you may also have a left shift. The compensatory response, for example, if one has an infection and they get acidotic, you may have tachypnea. But you may also have organ dysfunction ending up with things like altered level of consciousness or hypotension. Now, if you have these symptoms, these conditions, this leads to reduced perfusion and reduced oxygen delivery to organs, which leads eventually to organ dysfunction. Now, there are certain things which affect the way our systems respond to pathogens. And one is like comorbidities, and here we are looking at conditions like HIV, diabetes, and so on. The pathogen itself also determines how the body will respond and how fast it will cause trouble. And then it also depends on the site of infection. For example, if you have meningitis, that is likely to give worse outcomes and higher mortality. And remember, all these things are driven by genetics. Now, after we have organ dysfunction, each organ manifests in a different way. And as you can see, if it is respiratory, you have a reduced partial pressure of oxygen. And in the nervous system, reduced level of consciousness. If you, in the cardiovascular, you have mean arterial pressure dropping. And all these things point what we use to calculate our SOFA score. And the more organs that you have that are affected, the more likely that your patient's outcome is going to be compromised. Each organ is affected in a different way, as shown in this pictogram. And such things as bone marrow suppression will have their own consequences. Myocardial dysfunction, as we are seeing more and more in COVID patients. So when we are assessing our patients who have sepsis, we need to go through each of these, each of the major systems so that we can intervene appropriately. Now, just to give us an idea of the common germs that may be involved in the pathogenesis of sepsis, if you're dealing with a pulmonary site, let us look at pneumococci, staphylococcus, as well as atypical germs like Mycoplasma, Legionella. Now we have COVID. In the abdomen, we must think about E. coli, Klebsiella, as well as anaerobic organisms. Fungi are also progressively becoming important in our environment. Streptococcus and MSSA are important in soft skin and soft tissue infections. gram-negative bacilli in the urinary system. When you are dealing with the CNS, let's not forget Neisseria, pneumococci, and also gram-positives. And when you are thinking about endocarditis, we have to think about MSSA and coagulase negative staphylococcus. Why this is important to know is because when you select your antibiotic, you have to, in your mind, even if you don't have the culture, know which are the likely bugs that are affecting your patient so that you can select antibiotics that are going to be helpful for that patient. Indeed, it has been shown that if a patient receives an appropriate antibiotic, their outcome dramatically improves. Now, this is a huge one, which is showing the things that can mimic sepsis. And it ranges from infections to things like endocrine problems, such as adrenal crisis and thyroid storms, poisoning such as salicylic intoxication, carbon monoxide intoxication. We can have other things like dermatologic problems, and indeed, there are many, many conditions which can mimic sepsis. So when assessing these patients, keep this in mind so that your choice of antibiotic and your choice of overall intervention is more narrowed towards either the sepsis or whatever other differential diagnosis you may be dealing with. So how do we deal with these patients who have sepsis? A history is very, very important. And this is because it will help you narrow down the likely organ that was the primary site of infection, as well as narrow down what complications the patient has had so that your interventions are tailored as such. Then a thorough physical examination is important. Here we are looking at the different organ systems, and we are looking for things like endocarditis, which may sometimes be difficult to diagnose, hidden abscesses, indwelling catheters, which may have been forgotten. All those things are important so that our patients get the various studies that we do will basically depend on the site that is suspected to be the primary site of infection. But we should consider doing the following: a full blood count, UEC, and liver function test. This will be important in terms of trends, as well as in terms of doing our SOFA score to characterize our patient's risk. Cultures need to be done, and depending on the site, different cultures are done, whether it is CSF culture, blood cultures, urine cultures, and so on. Indeed, it is said that before you give an antibiotic, please draw the appropriate sample so that you can have the best chance of growing something. But remember, if you are going to delay giving the antibiotic to draw a culture, then just give the antibiotic and do your cultures when circumstances allow. Doing a lactic acid is important because it will help you chart how the patient is improving. So you do a lactic acid at the time you see the patient, and then you follow up over the next few hours and check for lactic acid clearance from blood. This will help you determine whether you are resuscitating your patient adequately or not. And then imaging will depend on where you expect your focus to be. Now, imaging has two aspects. There's the diagnostic imaging, for example, a simple chest X-ray, but there's also the interventional imaging. For instance, if one has a empyema thoracis, you may want to do a pleural tap or under ultrasound guidance. Or if you suspect a patient has got an abscess in the abdomen, you may want to do an ultrasound or a CT scan. And during the same time, you may want to put in a drain for that abscess. Now we look at principles. What do we do when this patient has come? Please screen for the patient, and this you can use different things. We've already alluded to QSOFA and SOFA. The immediate thing you must do is resuscitation. So here, resuscitation, you are going to give IV fluids, give vasopressors if they do not respond to the IV fluids. And in the past, you have been talking about goals at 1 hour, goals at 3 hours, goals at 6 hours. And the recent studies have shown that patients cannot be bound in hours. So do what needs to be done as soon as possible. For example, if your patient comes in, don't wait for the second hour to administer antibiotics if you can administer them within the first hour. Obtain blood cultures and quickly administer your antibiotics. Then you are going to give your patient fluids, and we'll discuss further on what fluids we need to do. There are those patients who will be extremely sick, and in this, we need to give them supportive therapies. Here we are talking about patients who will need mechanical ventilation, and we need to consider using lung protective ventilation strategies. Some patients will need renal replacement therapy. Others, especially if they stay in the hospital for many hours or days, they will need a nutritional input. For patients who have diabetes or those who have abnormal sugars, we will need to maintain their blood glucose level, and we can all remember the sweet sugar study, which showed that the tighter the control, the worse the outcome. So we are talking about a sugar between 8 and 10.
Niliona ni kama ni pants, imagine.
Then we also have to consider transfusions in patients in whom the HB is low, and we have to give the patient venous thromboembolism prophylaxis. Especially currently with the COVID-19, we have seen very many patients who have succumbed to pulmonary thromboembolism, and thus our practice needs to change in that way. Finally, if we were to take this patient to ICU and ventilate them, we have to minimize sedation, and as soon as it's feasible, we start mobilizing the patient, either by sitting them out of bed, walking them, and sometimes we even walk them when they are on the ventilator. This should not, a ventilator should not prevent a patient from walking around. Now, in a patient whom you have, they still are in shock, consider using steroids. This is hydrocortisone or methylprednisolone, whatever you may prefer, because this has been found to be useful in reversing shock. Let us look at each of these interventions in greater details. Fluid management is useful because sepsis is associated with vasodilatation that lowers your blood pressure. Because of endothelial dysfunction, patients have capillary leak and therefore ending up with ineffective circulating blood volume. This also leads to a reduction in venous return. For patients who come in, you need to give them adequate fluids. And what we mean by adequate fluid is 30 milliliters per kilo ideal body weight in the first 3 hours. It is important to monitor these patients as you give these fluids so that you don't end up over resuscitating them and leading to things like pulmonary edema. So when you're giving these fluids, it's very, very important to watch out so that you don't cause a secondary insult or a secondary injury to the patient. We know very well if we give too much fluid, we can cause organ edema, especially as far as the kidney is concerned, intra-abdominal hypertension, which will worsen your sepsis, as well as worsen your renal dysfunction. And we know that excessive fluids can lead to prolonged ICU stay and even increased risk of death. So first 3 hours, you are rescuing these patients. And here is where we say you give up to 30 milliliters per kilo ideal body weight. And this will help reverse the hypoperfusion and shock. After that, assess your patient, decide whether they need additional fluids, because some of them will not be at vascular diseases and renal diseases, because this may not be able to handle fluids well. Then you stabilize the patient. Trying to do is you balance your input with your output on the assumption that you have already resuscitated your patient adequately. Now, it is important to try and achieve a slightly negative balance because this helps your pulmonary system too. not to get overwhelmed. And then the final step is de-escalation. And this is as the shock resolves, so that sometimes you may even need to do aggressive fluid removal strategies, even including use of diuretics. Now, when you are giving these fluids, it needs to be dynamic. It is not that you do a CVP in the morning and you forget about it. Indeed, CVP is one of those things that I mentioned mainly to be discouraged, but you can use a trend if you are unable to do anything else. You know that your patient requires fluids if you do a straight leg raising test and you find that their pulse rate drops and their blood pressure improves. In that case, you know that, well, this patient will benefit from a fluid bolus. And how this straight leg raising works is that you put your patient flat, elevate their limbs for about monitor their pulse as well as their blood pressure. By raising the lower limbs, you are infusing, in quotes, about 300 milliliters of fluid in this patient. And if their BP and their pulse improve, then you know that you have room to give them more fluids. But of course, there are higher tech means of assessing this, such as thermodilution, echocardiography, looking at the inferior vena cava, and all those. All those are things which you can use in the good ICUs. So what fluid do you use? And there's growing evidence that crystalloids do well. In fact, for many years now, we have not been using things like colloids because they have been shown not to have any proven benefits. Albumin at times is considered, but there's a study which showed it has not much benefit in terms of resuscitating patients who have septic shock, and it is also costly because if you look at 2 liters of saline, that will cost you less than 1,000 shillings. But if you look at 300 ml of albumin, you may find you're using 30, 40. Please use your balanced crystalloids. And these are the studies which have been used to help determine what is it that we use. And what I would like to highlight is that when one uses balanced solutions compared with saline, there are lower rates of mortality and need of renal replacement. So you are better off with there's no benefit of using albumin, like this Caironi study of 2014 showed that there was no reduction in mortality, need of renal replacement, or length of stay with albumin replacement compared to the balanced solution. So there is quite enough data to support the use of balanced solutions. One has to ask is, what antibiotic am I going to use? What timing am I going to, timing do we need to use when we are giving antibiotics? Do you give in an hour? Do you give in 2 hours? What? And also, what duration of antibiotics is necessary to bring sepsis under control? And what we know is that appropriate antimicrobial should be initiated within the first hour of recognizing better. Now, the empiric choice of antibiotics, as we had discussed before, depends on the site of infection. It also depends on, has this patient used any antibiotic in the last 90 days, so to speak? Because if they have used a certain class of antibiotics, it's because you are likely to have drug-resistant germs. It is also important to know what the local pathogen susceptibility patterns you are dealing with. Because, for example, in our circumstances, things like methicillin-resistant staphylococcus, which so it's important to know how do our germs behave as far as antibiotics are concerned. In patients who are immunosuppressed, you may want to a different set of antibiotics because the type of infections they'll get is likely to be different, as well as risk factors for resistant organisms. Has this patient been in hospital for many days? Has this patient had surgery and things like that? The other thing we have to remember is that we need to give these patients appropriate dose of antibiotic. And what has been found for most antibiotics is that a loading dose is important to achieve a high therapy, an early therapeutic blood level compared and achieving that therapeutic level much later. There are some antibiotics which you need therapeutic drug monitoring to prevent side effects, and therefore one may need to have an ID or a pharmacy consult. These days, you are getting more and more fungal infections, especially for patients who have different types of immunosuppressions, patients who have used long-term broad-spectrum antibiotics. These ones, one has to consider antifungals. Consider them early. Even if you start with an antibiotic and you find your patient is not improving, consider an antifungal early. Then there's de-escalation and early cessation. And studies have actually shown that even some severe pneumonias can be treated with just 3 days of antibiotics. So let us not give antibiotics interminably, especially if our patients have improved in terms of fever has settled, their signs of sepsis have settled. Let us stop the antibiotics as soon as patients have improved. However, with certain germs or certain infections such as endocarditis or fungal infections, it is reasonable to prolong your antimicrobial treatment as you have a patient who still has signs of sepsis. There are some infections indeed where they say you have to give an antibiotic for a given duration of time. For if you are dealing with osteomyelitis causing sepsis, they say you have to treat for about 42 days. Let's do that. Then source control is another important thing we have to always remember. And sources can be either surgical or non-surgical. Let's remember things like IV lines, skin breaks like bed sores, having necrosis, maybe they're in the gluteal region, so they are always getting reinfected. So let us try and see how we can control the source of this. If you have an infected viscera, for example, a gallbladder or an abscess within the abdomen, the surgeon may have to go in and get rid of that before you can bring the infection under control. When do we use vasopressors? We use these vasopressors in those patients who have low blood pressure and therefore give an adequate fluid resuscitation. Do we have one vasopressor better than the others? Really not, but there are some which have been used more and they have more evidence. For example, norepinephrine in our circumstances is what many of us will use. But for different kind of patients, for example, patients with arrhythmias, one may want to use things like phenylephrine. So even when you choose your vasopressors, have the whole patient in mind and select appropriately. Our target mean arterial pressure is 65 millimeters of mercury in patients who do not have hypertension. But in those who have chronic hypertension, they may not tolerate such a low blood pressure. So you may need to give a higher level of vasopressors to achieve good tissue perfusion. Corticosteroids can be used when one has tried to use vasopressors and they are not improving the blood pressure. Improve clinical outcomes or survival. Remember always the side effects. For example, right now when we are using lots of steroids in patients who have COVID sepsis, we are ending up with many diabetics. Whether it's just the steroids or partly due to the COVID is something we will know as time goes by. When do you use biomarkers such as procalcitonin, C-reactive protein, and so on? It has been said that procalcitonin is good in discriminating when you're dealing with inflammation due to other things compared to inflammation due to bacteria. But in our circumstances, some of the things which work against us is that all these biomarkers tend to be expensive, and using them serially can be a huge burden to the patient. The other thing is that they are not available everywhere. So let us use a clinical criteria as much as we can, but if they are available, they are good for us to be able to fine-tune our patient management. One good thing with these biomarkers such as C-reactive protein and procalcitonin decide when to stop the antibiotics. When they have normalized or they have had a persistent low trending low, then one can decide to stop antibiotics sooner rather than later, compared to when you did not have these biomarkers. So let us remember that sepsis is a multifaceted disease. Its management is complex, and simplified guidelines for our circumstances are going to be very, very Back to you, Nyale.
Hello. Thank you very much, Dr. Waweru Munywa, for that talk on sepsis. I think somebody was having some challenge with audio. Is he able to hear us now? I think we hit at least 100 guys. Thank you for that update on sepsis, so at least people know what sepsis is. They now can define it and they can assess it. Then you've told us that it's an interaction of many things. It's not just the infection, but the patient as well and his comorbidities and the environment, because those bugs can come with other things, including resistance. You've also talked to us about systemic inflammatory response syndrome, and that it can be caused by many things, but it doesn't become sepsis unless we see an infection or a proven or documented infection. And then you've told us how to approach sepsis, the various aspects that we must look, how to prognosticate, the long and the short of it, and generally the principles of management. So thank you very much for that very elucidating talk. I think now I'll invite Dr. Diana Marango to just add a few things, probably for 5 minutes, on differences in sepsis in children. We call them the young adults. Dr. Marango, please. Dr. Marango is a pediatric pulmonologist working at University of Nairobi. She's the only PhD pediatric pulmonologist I know. So welcome, Dr. Marango. You can begin when ready.
Thank you. Can you hear me and can you see me? Thank you.
Yes, we can see you.
And also Dr. Waweru, that was very comprehensive. It was an excellent presentation, and concur with you. Even in children, it's common, it's costly, it's deadly. But I think, as you've emphasized, it's preventable and treatable. And just to realize that, you know, when you talk about the burden of pediatric sepsis, I saw this paper that had over 7,000 children, and this is an international study in 26 countries in about 128 PICUs. 3 PICUs were in Africa, but they were all in South Africa. And they showed that the point prevalence of pediatric sepsis, the severe sepsis, was about almost 10%. And the bulk of these children lay between 8 months to 11 years, with a median of 3 years. And as aptly put, respiratory sites are very frequent. 1 in 4 children will pass away in these PICUs. And of those who survive, almost 1 in 5 will develop at least a moderate disability. So this is really a significant illness. And some key differences, and this is not to oversimplify, remember that already in pediatrics, as you know, first of all, we know children are not small adults, Dr. Nyale. And also, even among children, we have the neonates, we have the child, we have the adolescent. So this is a spectrum. The etiologies, as you said, pneumonia is quite common. For us, hypotension is a very late sign. We want to pick these children much earlier. Giving fluids, and we'll talk just a little bit more about just a few of the controversies here, but epi is really the first line when we have to give in our resuscitation. And for the best outcomes, you want to have early interventions in that first hour, and this reduces mortality by twofold. And we can see the mortality, the outcomes are actually better in children than in adults. And I just want the audience to know that there's this 2020 Surviving Sepsis campaign. There are international guidelines for the management of septic shock and sepsis-associated organ dysfunction in children. Very comprehensive document where they looked at these 6 main areas, and they ended up coming up with 77 statements, all very interesting and well-researched, and 6 of them being strong recommendations. Here, what I just want to highlight, I don't understand why I have an echo, but is what you said, Dr. Waweru, starting the antimicrobial therapy as soon as possible. So it's as soon as possible, but at least within 1 hour of recognition, especially in children with septic shock. You touched on when to remove IV devices when there's confirmed sepsis. And these guidelines also have very strong recommendations against certain practices. So we don't want to overload these children, especially in health systems that don't have this availability of PICUs. And when children do not have hypotension, then avoid the bolusing and just start the maintenance. There's no evidence for the starches. There's no evidence for inhaled nitric oxide. This is not something that we have even here commonly. And of course, you talked about the tight glucose control. It's against, the recommendations were against insulin therapy for below 7.8 glucose that is below 7.8 millimoles per liter. There are many algorithms and protocols that we can follow, starting from our basic pediatric guidelines, which have been simplified, and their Ministry of Health, that we can walk around in our phones, in our pockets. And also just add on, there are also other guidelines from like for example, the American College of Critical Care Medicine. And here they expound a little bit about, when is it fluid refractory shock? Then when is it catecholamine resistant shock? And what to do in the different aspects when the pressures are low, normal, low, or if it's cold shock or if it's warm shock. So this is really just as a teaser and showing you what is out there. And something that I'm really excited about is, we've been extrapolating so many things from pediatric guidelines. So even from the sepsis 3 that Dr. Waweru talked about earlier on, these are adult data. They did not have any pediatric cases there. So one of the initiatives last year was our pediatric sepsis definition task force was developed to actually undertake what is sepsis in children, really. And I was just very excited to see that there's this protocol that is out in the public domain that was published this year. And one of the pediatricians, Samuel Akech, who's worked a lot, especially in the FIST trial, and is really a leading researcher in this, is actually on this protocol. So there's ongoing research when it comes to pediatric sepsis. So with that, actually, these were the only slides I had as a teasers. I'll stop sharing, and thank you very much for your for listening.
Thank you very much, Diana. You've lived up to the billing, a true teacher you are. And we think you should take it further. We expect to see you in most of those papers and channel a lot of knowledge about pediatric shock. I want to give a few minutes, 3 minutes, to Dr. Hassan Ali, the other panelist. Dr. Hassan Ali is a consultant physician, a pulmonologist, specialist pulmonologist, and intensive care physician practicing at the Aga Khan Hospital. He trained in his pulmonology and critical care at the Witwatersrand University in South Africa. I wanted him to give us a few aspects and a few nudges on how to manage shock. Dr. Hassan Ali.
Thank you very much. I hope you can hear me now.
Yes, we can hear you, but we can't see you.
Okay. All right. There, now you can see me. All right, so I think an excellent presentation by Dr. Waweru and Dr. Diana. I'm not a pediatrician, so I won't be able to talk about pediatrics, but as an intensivist, I'll just give you a few things that what I practice practically in my unit, and most of the time it's with the private consultants and my own patients. So what Dr. Waweru and what Diana talked about is the use of antibiotics. And I think early use of antibiotics is very, very important. Anand Kumar's study did show that any patient who had septic shock, every hour delay, there was increased mortality by 7.6%, which I think Dr. Waweru rightfully alluded to. What I normally do, and I think a lot of intensivists, especially because we do not have MICs in our unit, is I give very high doses of antibiotics from the start. So if I were to use meropenem, for example, I give 2 grams start and then 2 grams 8-hourly. Even if patients have got acute kidney injury secondary to sepsis, and there's a lot of data coming out now, and that, you know, even if you have patients who've got acute kidney injury, and I've used it in, I think, 5 of my patients who have had creatinines of around 300 plus, but with sepsis, and you give a full dose for the first 48 hours. Now, what I mean is that what Dr. Waweru alluded to was about giving 2 grams, the loading dose is to reach a steady state level earlier. So what I do is normally, you know, many times what we do is we write 2 grams loading dose start and then 2 grams 8-hourly. But what I normally do is ask the nurse to get 4 grams immediately and then give the 4 grams at that point in time, because what happens is most of the time when you write 2 grams start and then 2 grams 8-hourly, they give after 8 hours. So basically you're giving a standard dose. With regards to testosterone, I give as an infusion. So also with meropenem, and there are a lot of studies which have come out now. And there's a very nice study which came out in December looking at the algorithmic use of antibiotics, specifically meropenem. If you do not know the organisms, then you give very high dose of 6 grams. And that's the standard everywhere, I think. Even in Europe, they use very, very high dose. I depend on the PCTs and CRPs as a surrogate marker. They're not perfect, but it helps guide me in, of course, with the clinical acumen. There's a very nice test which has come out, which is FDA approved. It's known as a Septicite test. It's a RNA transcript which looks at 4 RNA transcript. It's CKM4, LAMP1, PLA2, PLAC8, and PLA2G7. Those are the transcripts that actually tells you whether this patient has got sepsis or not. And it's the turnaround time, I think, was 6 hours, and now they've come down to 90 minutes. So I think we are getting there. It is a very difficult choice. Of course, the PROMISE process and the ARISE trial showed that, you know, you do not resuscitate. Early goal-directed therapy is not more used. In fact, there's a very nice article that has come out that if you give fluids, if a patient is having septic shock and you start with fluids, you can give mini boluses of many 100 or 200 mils. If there is no rise in your MAPS, then you should start side by side with your fluids inopressors. And the inopressors of choice, of course, is Norepi. So I think most of the stuff that has been alluded to has been very well presented by Dr. Waweru. I use Qsofasol in HDU and all. It gives me a good guidance for my patients. So I use the 3 criteria, the rest rate, systolic blood pressure, and the mentation as a guide for ongoing of sepsis or not in those patients. So that's all I have to say for the time being. Thank you.
Yes, thank you very much, Dr. Hassan Ali. I think right now, probably before we go to the question and answer session, I think it's only fair we give the sponsors, DAFRA, 5 minutes. Basically, I think John Dung will introduce your speaker, and then after that we can jump into the Q&A session.
Thank you, Dr. Nyali. And I think my aim is just to introduce DAFRA Pharma, who partnered with the rest of for today. And on our behalf, we have Mr. Bruno De Pauw, who will be presenting for us, and he's all the way from Belgium. And without much further ado, I think, Mr. Bruno, you can start right away.
Hello, I hope that everyone can hear me. So my name is Bruno. I'm the international brand manager and training manager of DAFRA Pharmaceuticals, meaning that my major occupation is to train our reps all over sub-Saharan Africa on the DAFRA drugs. And today, in line with discussed, and I will share my screen. I hope that you can see my screen right now. Today I will talk on Meronia. Meronia is the meropenem of DAFRA Pharmaceuticals that comes in 0.5 gram and 1 gram. We call it the zero tolerance antibiotic. Zero tolerance because it is a well-known drug for severe infections. So as I said, there are 2 different forms, the 500 milligram and the 1 gram. For those who don't know meropenem, it is carbapenem, which is a subclass of beta-lactam antibiotics, bactericidal, and with a time-dependent killing.
Hello,
Yes,
Bruno.
sorry. Yeah.
Your slides are a bit small. You could probably enlarge them so that we're able to see your slides.
You can't see my slides?
Yeah, they're pretty small. We can't see them. There's an enlarge button.
Sorry, then I had a screen share, but perhaps it didn't work like it should be.
Okay.
Right now,
you
is
could
it
put it
okay?
again. Just put it again, then probably we can continue. You can just put the PowerPoint again. We can continue.
You can't see it anymore?
Now we can see them, but you're not on PowerPoint presentation. You cannot put them
on slideshow.
On slideshow.
Yeah, like this. Is it okay right now?
Okay,
Don't use a presenter view.
So slide view this way.
Swap presenters view slideshow.
Yes.
Yeah.
Yeah. Can you see it like this way?
If you can change from the presenter view, we'll be able to see a bigger slide.
Just a moment. Can you see it right now? Sorry for the inconvenience.
Okay, I think we just continue. So at least we'll be able to make it out. But we can, or you can go to the way they were before. Yes, that's much better.
This is much better. Okay, I'll do it
better.
this way. Further.
Yes.
So, sorry for the small interruption. Meronia, as I said, is a carbapenem antibiotic with a time-dependent killing. In general, it is said that time-dependent killing, meaning that it's not the total amount, the total concentration in the body that counts, but it's the time the concentration remains above the minimal inhibitory concentration. What is specific on Meronia? it distributes very well in many tissues and body fluids. So it's applicable for a whole lot of bacterial infections, with one exception, and that are the atypical bacteria. None of the carbapenem, none of the beta-lactam antibiotics will work against atypical bacteria. If you see at the microbiology and the germs that are covered, you will see that it can be considered as a really powerful antibiotic, indicated for in adults and in children as of 3 months of age, compared to the other available carbapenems, is the only one that can be used officially in children as of 3 months of age. And there are many clinical data that are even used for younger children. It is a very wide indication spectrum. I won't go into details, with also a posology that is valid for adults and children. In adults, the normal posology, and I don't speak of sepsis over here, is 500 milligram to 1 gram 3 times a day. So each 8 hours, as an IV bolus injection, an IV infusion, and later on, I also will talk on the prolonged, on the summary of product characteristics. More and more, we see that a prolonged infusion with meropenem is feasible. This isn't feasible with other carbapenem drugs. For children under 3 months of age, the pharmacokinetic data suggests that a regimen of 20 milligram per kilogram every 8 hours may be appropriate. If there is renal failure, renal, with a clearance of less than 51 ml per minute, the dosage should be adapted, or the frequency should also be adapted. Meronia as a drug is produced within Europe. It applies to all European standards. It has a really good shelf life, up to 4 years at room temperature, below 30 degrees centigrade. But after reconstitution, the molecule is not very stable. So in general, it is advised to use it immediately. And to prepare the solutions, mostly it is done with physiological serum. And over here you can see that the stability after reconstitution is at maximum 8 hours if the room temperature remains below 25 degrees. Above 25 degrees, the drug degrades rapidly. Compared to other carbapenems, Meronia is more stable. So this enables that it also is used with a prolonged infusion. And more in literature, we see that a prolonged infusion versus intermittent bolus injections have a higher clinical improvement rate and the lower mortality in patients. It is recommended for patients with severe infections or infected by less sensitive microbes. This is one of the publications. Another one saying exactly the same thing. The patients within the continuous treatment group received a loading dose over here of 500 milligram, followed immediately by a continuous infusion of 3 grams of meropenem over 24 hours. I need to say that this is in patients with sepsis and without renal dysfunction. I won't go for other, I won't promote other dosing regimens. This is up to you, the clinicians, to do it. And shortly, as a conclusion, we call it a zero tolerance antibiotic, the right approach for severe infections at a really interesting price compared to the originator brand in Kenya. It's about 1/3 of the price, and it's also available in the major private hospitals. And this is what I would like to say on Meronia.
Thank you very much, Bruno, for that presentation on Meronia. I think now we'll jump into the question and answer session. I think we have about 20 or so minutes, but I've looked, the questions are not many. First question came from Dr. Loch. Explain the applicability of the infectious ISSS bundle to African healthcare. Infectious severe sepsis care bundle to African healthcare. One of the panelists, maybe Waweru, you can have a go about this bundle.
Yeah, thank you, Nyale. The International Sepsis Care Bundle basically demands that when one is managing this patient, they do a lactate, early blood cultures, preferably before antibiotic administration, antibiotic administration within the first hour, adequate IV fluid resuscitation, and vasopressors if the blood pressure does not respond to fluid resuscitation. All these things are very good and beautiful on paper, but we can recognize that even diagnosing sepsis in our circumstances is difficult. For those who are working in a tertiary level of care, that usually is not a major problem. But if one is in the smaller hospitals, even doing a blood gas, there may be no machine to do that. Getting blood cultures in some hospitals is next to impossible. Antibiotics, the number of antibiotics available may be a problem. You may find that a hospital has only doxycycline, amoxicillin, and if you are lucky, you get ciprofloxacin or something like that. IV fluids may be available, but sometimes people don't even recognize the need to give adequate amounts. You may find a patient has had half a liter of Ringer's lactate running from 6 a.m. to 6 p.m. And also the suppressors are affected because we are not able to monitor these patients adequately. And thus the need for us to generate data which will use maybe bedside or clinical criteria to determine what it is we want to give our patients. If I may delve a bit in Dr. Marangu's area, there was a study called Fluid Expansion as Supportive Therapy, where they were giving children adequate or rather boluses of fluids. And actually this was found to be harmful in those areas where it was not being monitored. So these things are very good if you're able to provide the right environment in terms of the right equipment, the right training of the human resource, and the right interventions in terms of medication, in terms of fluids, and so on. Thank you, Nyale.
Hello. Yes. Hassan Ali, what is your experience? Do you think these bundles work for Africa healthcare? Or is it that we are left behind? And if you are left behind, what are probably solutions that we can use to circumvent our problems?
Thank you, Niall. There was a very nice article that came out following the sepsis 3 definition. And they say that in resource poor settings, lactate may be a problem in terms of accessibility. And what they said was, and what the writer or the author proposed was the use of capillary refill. And I think it's a good idea. We have to find our own way of how to best find out our own bundles that will work best for us. I know the only problem I have, because remember, you have also trained in South Africa, our broad spectrum antibiotic of choice in the critical care unit was Augmentin. But because of the circumstances that we have here, that everybody is prescribing antibiotics, even the pharmacist you can get over the counter. So it becomes very, very difficult. By the time the patients come with sepsis or septic shock, they have taken a gamut of antibiotics, and it's very, very difficult that you're forced to use a broad spectrum antibiotic. I think if there are laws that it's only a prescription based antibiotic be given, then I think we probably will be following suit like in every other country in the world, whereby then we'll have antibiotic stewardship program. And I think the other thing which is very important, even if you have the thing which that helps in even resource poor setting is SLR, straight leg raising test, which anybody can do it. If a patient is fluid deplete, you can do it. Just tells you whether there is fluid responsiveness to this patient or not. Raise your legs up for a minute or two at a 45-degree angle and see if there is any increase in your blood pressure, mainly your MAPS by 10 millimeters of mercury. Then you know that this patient is fluid responsive, and one can do that. So I think it's what you rightfully and what Dr. Wawe rightfully, we have to find our own ways. The FIST trial in pediatrics was dismal in terms of giving too much of fluids, and it was negative. And so also with regards to the early goal-directed therapy, I think what we should be aiming for is precision medicine. What is best for your patient, rather than one size fits all for everybody who comes with severe sepsis or septic shock. That's my take home. Thank you.
Okay, so I think most of you are saying that the problem, like what failed in the first trial in the pediatric with the fluid boluses, was that people were getting too much. And Dr. Andrew Ward asked a question about point of care ultrasound in sepsis. Does it have a role? Because you can be able to do to assess status using an. Diana, you can give us something, please. Mary Boniface, switch off your mic. Diana, you can comment on
about the point of care ultrasound.
Yes.
Yeah, absolutely. I'm very excited about point of care ultrasound for a number of things. Yes, its role in septic, shock in fluid, monitoring fluid balance. Also, I can see its role, especially like just as a as a pulmonologist, making diagnosis, is this interstitial lung disease, fluid overload, is this pleural effusion? So, and I think I don't have experience about I've used it for those two reasons, but I don't have experience also maybe looking at heart, actually point of care, cardiac imaging, but that can also be very useful. So I think this is exciting times and we should be exploring. And I've seen a number of studies and also protocols that are ongoing, focusing on point of care ultrasound in sepsis in children. So Andrew, yes, exciting times. Thank you.
Where would you like to add something about point of care? Because I know people are now they're looking at the IVC if it's collapsed to know that you're still fluid deficient. And if people think you have a heart issue, they look for pulmonary edema, that's the Z lines on the ultrasound. And then just by even eyeballing, you can look at how hyperactive the heart is to be able to know that this heart basically is hyperactive and you have an IVC that's collapsing, probably you need more fluid. Your comment, Dr. Aweru, on point of care ultrasound in sepsis?
Yes, I would agree that it is one of the best things that have happened in terms of sepsis management. Its role starts even with diagnosis. For example, if you do point of care ultrasound in the abdomen, you'll be able to pick many things, starting with the appendix, the gallbladder, differentiating from bleeding, like a ruptured ectopic or abdominal injury, ruptured spleen, and so on. When you are intervening, it will help you in terms of putting lines, in terms of monitoring your fluid responsiveness. For example, if you do the echo, you find that if your right ventricle is increasing in size without a concomitant increase in stroke volume, then you know you have reached your limit. Alternatively, if you find that your left ventricle is not, the ejection fraction is low, that's a patient in whom you have to be very wary about fluid overload. Differential diagnosis also in other organs, you've already alluded to pneumonia, empyema also, and you can diagnose as well as insert a drain with under ultrasound guidance. Soft tissue infections like abscesses or even fasciitis, necrotizing fasciitis, all these are uses where ultrasound can be very, conditions where ultrasound can be very useful, amongst many others. So yes, it's a very important tool we have.
Okay, I think, and there are a lot of other things that will come up with ultrasound, basically to be able to even, there are now mechanics that you can actually be able to put and they can actually estimate for your cardiac output. The other question that Andrew Warrer has asked here is your approach to antibiotics. And I know most of the people who trained in the South, they like the early big doses, and the people from America do like small doses, but in a continuous manner. I'm not sure whether that battle can be settled today. I know Hassan Ali is a guy of big doses, and then Tepa when things are better. But I don't know.
If I can add to that.
Dr. Nyali.
Yes, just a minute, Anguche. Let Hassan Ali first finish, then we can give you something to say. Yes, Hassan Ali, go first, then we'll have Anguche after that.
So the reason, I'll give you my reason why I use high doses, and I think it's very valid, because you see, one of the commonest cause of inappropriate antibiotic is subtherapeutic dosing. For most hospitals, I don't know about Nairobi Hospital per se or anywhere else, we don't get our MICs for our patients. Number two, we do not know what organism you're dealing with at the time when the patient comes with sepsis or septic shock. And I follow the intensivists who believe in, and what Bruno had talked about, it being a time-dependent antibiotic, rightfully so. If you want a bactericidal effect, your time above the MIC has to be 40%. Why not 100%? Why not have my antibiotic at 100% above the MIC when I'm sure then I do not have to worry about resistance? The question that people will always say is about toxicity. With all honesty, in this 5 years that I practiced medicine, I've yet to see one toxicity with regards to high dose meropenem or any other antibiotics for this, except for imipenem. I've had problems with imipenem with regards to seizures when I used 4 grams of imipenem. But otherwise, because I don't have MICs, then it becomes very, very difficult as a clinician, as an intensivist, that what dose should I give a patient? In the West and all, they have the facilities of doing MICs. We do not have that facilities in my this thing. And even if you don't have an organism, then it's better to hit hard and fast rather than go slow. And this is my take home.
Okay, we've had your view. Anguche, what's your view? You can also take the view from Aloch and Owar, so that I think it's evolving into a discussion.
Yeah, Dr. Nyale, thank you very much for your awesome moderation tonight, and for all the other participants, especially Diana, my good friend. Thank you for the awesome presentation. I think when we're talking about antibiotics, we need to differentiate quite a bit, because if I'm talking about penicillins, if I'm talking about carbapenems, if I'm talking about monobactams, then like Bruno says, the amount of time, the duration during which the concentration is above the minimum inhibitory concentration, the better for the therapy. And we actually have very, very intensive and extensive experience about using infusion pumps over hours when we are dealing with this antibiotics like penicillins, carbapenems, and monobactams. But we also have other antibiotics, for instance, the fluoroquinolones. When I'm talking about tetracyclines, these are antibiotics which work intracellularly, and they have a very great post-antibiotic effect. So there's no way I'm going, for instance, to give a fluoroquinolone for such in an infusion pump. So for that, I will actually give 1 dose a day, but a very, very high dose. So I'd like us to actually differentiate the antibiotics. Not every antibiotic can actually be given in a prolonged fashion. That was my comment about antibiotics. And we are lucky here, we have this therapeutic dose measurements so that we can actually steer the therapy properly. The other comment, passing comment I'd like to make is about ultrasonography in septic patients, but in general in all critical patients. I actually think if I had a way, then I would actually say a law should be passed to outlaw anyone walking around in the intensive care unit without this toy called the ultrasound, because the possibilities are actually infinite. And they have been listed by everyone who's talked about it. And this is from intensive and extensive experience. So I would encourage anyone to actually embrace this, and actually the ability to learn how to use it is you pick it up very, very fast with a short experience, within a short time. Those were my comments tonight.
Okay, you gave us an extra one. We're looking at antibiotics. I think let me bring Joseph Aloch. Joseph Aloch is the grandfather of chest medicine in Kenya. We always talk about this time of IMIC, area under peak of trough levels. To you, how do you dose your meropenem? Because I know people get very passionate when they are criticized about what dose they picked.
Sorry, Dr. Nyale, I cannot talk much about those things at the moment, because I don't use a lot of them. I don't work a lot in ICU. I avoid ICU. But I can just comment about, because I'm very keen on the basic principle of challenges of sepsis in Africa. And I think one of the most things is to prioritize awareness, get awareness and capacity building among the health workers and about sepsis and its management. You should promote early sepsis recognition as a feature of sepsis may be subtle, and early recognition and management bundle for this service should be developed to affect primary, secondary, and tertiary level of care. We should not say that we cannot do this because we don't have this at this level, as Dr. Owero was trying to imply, but rather we should develop these bundles that can be used at the 3 levels, primary, secondary, tertiary care of the hospital, which include the use of validated EWS and SIRS criteria to identify patients with sepsis, rapid administration of oxygen, IVs, antibiotics, and measurement of fluid balance, lactate measurement, which can actually be done even at a lower level. So I think we have to agree that this criteria of managing sepsis should be done at all levels. Otherwise, we're going to make it just an exclusive or an elite club of the people with sepsis, only if they meet aware that they can be properly managed. But there are a lot of sepsis outside elite centers. So I think we have to develop criteria for using by healthcare workers to manage sepsis at all levels. Thank you.
Okay, I thought Dr. Aloch said it's the patient's right to choose the doctor, and the doctor is what you get. Anyway, Dr. Awar, please comment about this sepsis in Africa and about antibiotics. And I would also want to comment about point of care ultrasound.
Okay, thank you so much, Dr. Nyale. My take with regards to point of care ultrasound, I think the speakers for today have dealt up a lot about it. And some of the challenges that we have is we may not be able to do the full SOFA. And I think if you're going to do a Q SOFA and it only has 3 components, then the point of care ultrasound, where an ultrasound is available. And I'm sure in many facilities, ultrasound is available. You should be able to make a diagnosis, like Diana had said, and you could actually make differentials for hypotension if and when you suspect that the patient could be having septic shock. There are times when we thought the patient has sepsis, and when you do your ultrasound, you actually find the patient has a pericardial effusion. Or if you're doing cardiac imaging, it could actually be signs of right ventricular strain that could actually suggest that this patient probably has pulmonary thromboembolism and maybe not actually an infective process going on, because sometimes some of these patients, if they come in shock, they may not have fever. They'll actually sometimes actually be hypothermic. With regards to antibiotics, I think Dr. Anguche has pointed it out. You need to know, I mean, when you're treating sepsis, they shall know their antibiotics. They are time-dependent antibiotics, they are concentration-dependent antibiotics. For the concentration-dependent antibiotics, for example, the quinolones, the aminoglycosides, those ones I can give a big dose once a day. For the time-dependent antibiotics, for example, the beta-lactams, then an infusion, for me, makes sense. And Dr. Hassanali, keep in mind that there are some patients who have augmented renal clearance. So you give them a high dose and they're just flushing it out. For me, where available, if you have an infusion pump, that would be the way to go for beta-lactams. Where you do not have infusion pumps, then I agree, Dr. Hassanali, that supradosing probably would be the way to go. Thank you.
Sorry, if I can,
this question,
answer Dr. Owuor.
Hassanali, through the chair, please.
Yeah.
We are not answering each other, but it's through the chair. I'll first want to give Masood a chance also. Dr. Salim Masood, I see you are logged in. Please tell us, how do you manage your sepsis in Africa, and what can we learn? A few nuggets from you, please, Dr. Masood.
Okay. Hello.
Hello, we can hear you, Masood. Go ahead.
Yes, sorry. I don't know which aspect you want me to talk about, but I think
you can choose the one you want to talk about. Any of those. Are you wanting to talk about, are you wanting to wade into the antibiotic war, or do you want to talk about fluids? Because there's been a lot about fluids, balanced and unbalanced fluids for resuscitation, for instance.
Yes, I think the antibiotics war has gone on for a while, so I would talk briefly about the fluids. So I think what Dr. Waweru mentioned is what it was basically recommended and what we follow, the dynamic fluid monitoring rather than the static fluid monitoring, looking at the blood pressure and the CVC, and you know, CVC also depends on the cardiac rhythm and all that. So the dynamic, because I think this is something which I've seen, especially in our MOs working in critical care, that I'm not very keen about. The straight leg raise, and if possible, the invasive monitoring of blood pressure and also fluids is a practice which was commonly in South Africa, especially with invasive monitoring. I mean, every patient in ICU in shock should get an airline and also be monitored. And basically, what Dr. Waweru was talking about, the pulse, whatever wave, using gadgets like the Vigileo. So I think that will be the way to go. And because there's a risk of giving patients over, I mean, a lot of fluids, and then they stay 1 or 2 days longer in ICU. So I think that will be my comment.
Okay. Okay. So airline, for those who don't know, it's just an arterial line. Eh? So don't get amazed about the big
The other thing is regarding airline, because I'm very pleased and surprisingly, I mean, nicely surprised that the intensive care unit, for example, in Kenyatta University Referral Hospital, they are putting everybody on airline and monitoring the blood pressure invasively. So that was a bit impressive, something I just discovered the other day. And I mean, I think that should be the standard for all the ICUs in the country. Because I mean, fluid is key, and giving too much fluid might be a problem. So we would want to do, I think it will be good to follow that route. Thank you.
Okay, I know, Masood, before you go, I know you like new things, yeah? You know, when Dr. Joseph was practicing, Dr. Joseph Aloch, we still had the Apache score. Do you still use Apache score? Just a question. Or does it appear in your ICU charts?
It should be. It should be. We used to do Apache score like when I was training a few years ago in South Africa. Everybody in it was given. I mean, was scored according to the Apache scores. So as an admission, and then after 2 days we repeat the Apache score. But the ICUs that I'm visiting and attending patients is not a practice. It's not routine. So maybe we can look into that as well. Many guys have switched to SOFA score, which is much simpler than Apache score, because Apache score is very comprehensive and requires a lot of also biochemical tests, which by the time you admit the patient may not be available immediately, and maybe can be what is challenging in our setup.
Okay, yes, Hassan Ali. Now, Hassan Ali, we want you to comment, yeah, not just on the dosing and the starting duration, because this is where there's a lot of trouble, especially with antimicrobial stewardship from the microbiologists. They stop your antibiotic on day 5 and you've got to explain to them why you've got to continue. And by the time you get an explanation, sometimes one dose has been missed. So you are almost like starting again.
Yeah, so a couple of comments. You see, the Prorata study which was done was based on PCT guided therapy. And if you look at the Society of Critical Care guidelines, they say you stop your antibiotics when your PCT is less than 0.1. But if you look at most of the other intensivists and we look at most of the studies that have shown, if your PCT has dropped by 80%, then you are very well likely to, you can very well stop your antibiotic. Now, with regards to the dosing that which is a contentious issue, the reason why you're giving high dose and as an infusion also, remember it's not giving just a bolus dosing, is because of one of the 3 things. One is augmented renal clearance, which Dr. Awar rightfully said. The other one is that most of these patients who are in septic shock or severe sepsis, they've got low albumin. So because it's a negative phase reactant, because of low albumin, most of these antibiotics are protein bound. So you're likely to lose more antibiotics if you give the standard dosing, even if as an infusion. That's the reason why you give a supranormal dosing. The third thing which normally happens in these patients is the volume of distribution is so high, because by the time the patient comes with septic shock, you're giving so much of fluids, the volume of distribution is high, and that's the reason why you have to give high. That's the main reason why you are giving high doses. If you had an MIC like Dr. Anguche's unit, I'm sure they would. Then I agree that you give normal dosing if your MICs are acceptable. But like what Salim talked about, that I think art lines and all are very, very important. Ultrasound is very, very, very important in every unit, that you should have one at least ultrasound, and we all should be well conversant with the use of ultrasound, I think.
Okay, just a question, Hassan Ali, and probably Anguche, you can answer this. Do you need an outline for each and every patient? Because usually we put in patients who have actually got a shock that is refractory, so that you are able to monitor the shock properly. Is it your standard practice in Germany to put everyone on an outline, Dr. Anguche?
Actually, that differs. For example, the unit I trained at, we actually used to only put arterial lines on patients who are extremely sick. But for the majority of the patients, they actually got capillary blood gas analysis. We actually used to rub their ears with something called phenalgone, and that would arterialize their earlobes, and we would actually do our ABGs from there. But in my current unit, the unit I lead right now, we actually put an A line on any patient who actually comes on the intensive care unit. But one has to relativize all of this, because the truth of the matter is arterial lines are actually also very dangerous. And because we are not the ones who actually insert them. I actually rarely insert arterial lines, so my registrars do this, and there's a whole range of registrars, from those who are just checking onto the intensive care unit, from those who actually have a lot of experience on the intensive care unit. So it all depends, but I don't think that it's a must that patients get arterial lines. On my unit, it's standard, but one has to take into consideration the dangers of an arterial line. I have once seen a hand being amputated because of complications of an arterial line. So they are not just to play around with, but it depends on the unit, it depends on the expertise, it depends on the available resource, manpower resource.
Dr. Nyale, can I make a comment?
Okay, we'll come after. I wanted to give Diana, then you come in. Diana, just comment on that in pediatrics before we get Patron Joseph Aloch to give us a comment.
So here in at least most of the ICUs, I know it depends on most people's expertise. I know Dr. Kaiser will put ACT lines, and this is because we trained a lot in South Africa. The other PICUs, which I'm not mainly in, it depends on who is leading that PICU. So it's also about the leadership. Again, also know your expertise, know the complications, and why you're using them. In the newborn unit, I remember as an intern, and what is it called? We do a lot of these as well. So again, pediatrics is a spectrum. They're the NICU guys, they're the PICU guys, and it'll depend really on your leadership when you start seeing the practice. Thank you.
Yeah, before you go, Diana, there was the issue that in most of these places, in most studies, people were given intravenous boluses. Because we gave them through the bone marrow, because children can absorb, if they are having fluid deficit, from the bone marrow very well. Would that have changed probably the first study outcome? Just a question, I'm just wondering. If we gave the fluid in a different format that wouldn't overload the cardiovascular system, would that have resulted in a lower mortality? I'm just guessing, such that if probably in the periphery, it would be safer to give fluid through that mode, or through oral rather than intravenous.
So maybe I didn't understand the question very well, but for us intraosseous, in shock, you don't even try to struggle putting a line in children. I don't even struggle. Your first access is an IO. And and this is something, I'm just going back to what Dr. Aloch said about bundles. They might not be put specifically as bundles, but what we've done, like with guidelines around shock nationally, is this basic pediatric protocol, and fluid, having who you're giving the fluids to. So IO is versus IV. I think they're going to be the same in terms of getting into the vascular space. IO just being faster, but I heard you talk about oral, which I didn't. That's why I didn't get the question. So
no, I was just saying in the first trial, the fluid boluses were intravenous, not intraosseous. But I stand corrected. I thought most of them were intravenous.
It was IO or IV, if I'm not wrong, but we can confirm.
But if you look at the paper in the first, most of them were IV. Okay, but then we can confirm.
Yeah,
and look at
I don't think there's any difference. But again, that was a trial in that context. Remember, most of our health system, we may not have that ability. And even if you see this 2020 surviving sepsis guidelines, they really reflect on this FEAST trial and avoiding large boluses. So those are not advised. Maybe I just didn't understand your full question, yeah. But we learned a lot from the FEAST trial, yeah.
Okay, then we can have a comment from Joseph Aloch, and then I've seen my deputy president, Dr. Anne Irungu, will comment last before we close this down. So, Patron, Dr. Joseph Aloch, you're...
Thank you, Dr. Nyale, Mr. President. Yeah, I just want to comment because you did talk that Apache was introduced early during our time. No, actually, Apache's core system was introduced in the 80s when I was already a retired doctor. It's not an old thing, so you should actually know it better than me. But it was introduced originally to kind of grade the severity of critical illness. But later on, it was found to be more useful in predicting individual survival. But above all, it was valuable for monitoring the quality of care and for conducting research, because they allow comparison of outcomes among groups of critically ill patients with similar illness and severity. Thank you.
Dr. Annie Rungu, Deputy President, please. Madam Deputy President. The Deputy President.
Good evening, Nyale, and everyone.
Good evening, Anne.
I really don't have anything specific to add beyond what Diana has presented so far, and the superb talk from Peter. That really was quite comprehensive. A lot of similarities between what we do in pediatrics and in adult medicine, but as always, I always emphasize, please know your doses, know your epidemiology, because there are some, that's where the main differences come from and will determine the kind of medications you use. About supradosing versus intravenous infusions, it really depends. So when we get an admission, the initial dose, we normally give the meropenem as a supradose, a bolus dose. And then when they're in the unit, depending on their stability, then we can switch to infusions. And also depends for us in pediatrics, how much fluid you're going to give. It will also determine the infusions that you use. There's a question right now that's been asked in the chat about if you have procalcitonin levels dropping, whether you switch to oral antibiotics. Again, it really goes with what your microbiology data is and how stable the patient is to be able to know whether you'll get the same bioavailability if you use an oral versus the IV, but preferably until a patient recovers from the sepsis and the infection, and they're still admitted, then we normally continue with intravenous infusions. So just emphasizing the same thing with what Peter said, same thing in pediatrics, hit hard, hit fast, and of course, if you have better resource centers, then usually your outcomes are pegged on that, if you're able to escalate the care.
Okay, thank you very much, all of you, for attending this talk. I know it has been very stimulating. There are a lot of things that we can debate till morning, including doses of antibiotics, whether the volume of distribution increases in acute critical care, because apart from augmented renal clearance, low albumin, you've got capillary leak. So you find the volume of distribution also going up, and probably that's where the supradosing is coming from. Well, the Americans do believe that the increased volume distribution doesn't occur at the beginning. If you start early enough, and a continuous infusion will actually be able to meet this increased volume of distribution. But it's been good and stimulating. I know we might never agree everything in shock. It's interesting to know that steroids, we forgot to talk about them. That should have been another one, but we have run out of time. They've always come in and out of fashion. But remember, if you're giving them in slow doses, not huge doses of steroids. And usually most people do 3 to 5 days. That's the max that you do when you're dealing with sepsis. About switching to oral, it's really the patient who tells you. Okay, I know people like intravenous and saying intravenous for 7 days because they earn money from seeing the patient. But really, it's when the patient has improved, he can be able to swallow, and the GI is able to digest, then you are comfortable as long as the bioavailability is not lost. So thank you very much, Peter. Thank you, Dr. Diana Marangi. Thank you, Dr. Hassan Ali, for this stimulating talk. And I think we should have a repeat of this again. Bruno, how I think we should have a repeat of this. And probably now we should take just one thing, fluid resuscitation in sepsis, and break it down so that people now can actually see what it means when we talk about balanced and unbalanced fluids. So thank you, everyone, and good night. I think, Dafra, dinner is served, yeah? Am I correct? Yes. Am I correct that dinner is served in Dubai?
Yes. Yes, it is sound that Mr.
All of you.
President.
All of you are welcome for dinner. We shall be sending
All
it
right.
on. Welcome. Okay.
Okay, thank you so much.
Good night. Okay, thank you.
Good night. Too. All right.
Ndio imeisha. I can see people.